The final chapter of the course is titled Death, Dying, and Grieving. We will begin by defining death, then move on to discussing decisions regarding life and death. We'll also discuss some of the common causes of death throughout the lifespan and developmental perspectives on death as how they change across the lifespan. So we'll be talking about some of the common ways that humans die from infancy through late adulthood, as well as how our perspective on death changes through early childhood and throughout adolescence and into adulthood. And then lastly, we'll talk about grieving and bereavement, with the major topic being Elizabeth Kubler-Ross's 5 stages of grief. So we begin with defining death. CPR has not always been around. There was a time when people would stop breathing and stop having a heartbeat. They would no longer have a pulse, and they were considered dead instantaneously. With the invention of CPR, we realized that we can, quote unquote, bring people back to life after they've stopped breathing and their heart has stopped beating. So to say that someone is dead when they stop breathing and their heart stops is not necessarily true. So what we do know is that once a person's electrical activity in the brain has ceased, they have established brain death, and that is the neurological definition of death, or the working definition of death, in the sense that there is no return from this. This includes all of the cerebral cortex and the brainstem, and it's important to note that because some people can have extensive brain damage and much of their brain can be dead, but so long as the brainstem is active, they will still be alive. So there are different situations that people can, or conditions that people can be in, such as a coma or a vegetative state, that may imitate or resemble death, but they are not. So in a coma, we have individuals who are unconscious. They are not responsive to external stimuli. They appear to be asleep, and for many people, this can last an indefinite amount of time. And then we have a vegetative state. Individuals who are in a vegetative state, such as the woman on the right, also highlighted in the case study of Terry Schiavo, these are individuals who have extensive brain damage and require assisted feeding, typically do not have the ability to move on their own or speak, and so they have a very low quality of life. The case study of Terry Schiavo is rather fascinating because it involved a major legal dispute in which a woman was under a vegetative state for many years. Her husband was intended to remove the feeding tube, basically stop her feedings, so that way she would die. And her parents strongly objected to this, and the husband won in court. And they essentially stopped feeding her through a tube, and she slowly starved to death, which sounds extremely traumatic. My understanding is that she was sedated, so she didn't experience any pain, but the truth of the matter is that it took her several days to die, and this is an example of euthanasia. We will discuss the difference between passive and active euthanasia in the coming slides. So why was there an issue between Terry Schiavo's husband and her parents at all? Well, that is because Terry Schiavo did not have advanced care planning. She had not established legal documentation that outlined her preferences for end-of-life care. So if someone enters a vegetative state or a coma and they require feeding tubes or ventilators to keep them alive, this is ultimately, if we want to stop using these feeding tubes and ventilators, that's going to be up to their legal guardian, in a sense, whether it be their parents or their spouse, depending on the state that they live in. And unfortunately for Terry Schiavo, she didn't have this outlined or documented. The truth of the matter is that not many people do, because obviously it requires legal fees, and many people, the odds of it happening to people are very slim, but it does happen to people. One of the other concepts associated with advanced care planning, besides feeding tubes and ventilators, is a do not resuscitate directive, DNR. And so this is a preference for not wanting CPR, not wanting to be resuscitated, basically saying that it's a preference for the individual when they stop breathing or they go unconscious or they don't have a pulse, then they don't want to be resuscitated by any means, specifically CPR. They want to be allowed to die. Every now and again, you'll see a news article where a DNR is ignored, and that can lead to other legal issues. So, euthanasia with regard to Terri Schiavo. What Terri Schiavo experienced was passive euthanasia. This is when treatment is withheld, when we remove the ventilator, we remove a feeding tube. This happens daily. This is a question that family members and spouses have to answer on a regular basis because most people do not have advanced care planning. Active euthanasia is much more controversial and has many different legal statuses across different states in our country. And some countries it's existed for many years, in some countries it doesn't exist. This is in which death is deliberately induced by the individual or a physician. This was pioneered in the United States by Dr. Jack Kevorkian. Dr. Jack Kevorkian helped many people end their own lives. Many of them were in extreme pain. They had chronic health issues such as cancer, or they were completely paralyzed, Lou Gehrig's disease, in extreme pain, and many of them wanted to end their own lives without having to go to the extreme measures of committing suicide using a firearm or using an automobile, and so they seek Dr. Jack Kevorkian's assistance. The quadriplegic, I believe that was his first client. I mean, it'd be very difficult to kill yourself as a quadriplegic if you don't have the ability to move. And so Dr. Kevorkian faced many legal issues. He lost his medical license, went to prison, but the truth of the matter is that active euthanasia has been legal in many European countries for many years, and it is now legal in many of the United States of America, including Oregon, Washington, and Montana. These legal bills are typically called Death with Dignity Acts, and it's a very controversial notion, especially when you're talking about concepts such as pro-life or pro-choice. We're talking about ending someone's life. We're talking about someone choosing to end their own life and seeking the assistance of a physician to do so. Many people who are experiencing a chronic disease or has end-stage cancer, they will typically find their death in a under hospice care. So hospices provide palliative care for people with terminal illnesses. They are trying to manage the pain and the symptoms associated with the terminal illness. They offer religious services and counseling services as well. The vast majority of their services takes place in the home. And it's also covered by social funding if the individual is given 6 months or less to live by a physician. So the most common causes of death throughout the lifespan are outlined below. In infancy, the most common cause of death is sudden infant death syndrome. This is most common between 2 and 4 months, and babies die on a daily basis from sudden infant death syndrome. In childhood, the most common causes of death are going to be accidental deaths and illnesses, things like drowning, motor vehicle accidents, fires. There are other causes of death in childhood. These are just the most common causes. And adolescence and young adulthood is a very, very interesting life stage because although motor vehicle accidents are still a common cause of death, it really is the first stage of life in which homicide and suicide become a common factor. And then in middle and late adulthood, typically the most common causes are going to be chronic illnesses like heart disease and cancer. Our perspective on death changes throughout the lifespan. In early childhood, we still do not have much experience with death. Much of our understanding of death comes from movies and TV shows. Many children are have maybe experienced the death of a pet. But some children do have to deal with the death of a loved one, of a family member, whether it be a parent, a sibling, or a grandparent. And it's certainly an uncomfortable discussion to have with a child, but psychologists recommend using both honesty and affection rather than making up some sort of lie like the person moved away. Middle childhood. At this point in life, most children understand that death is an irreversible and natural process. Typically, by middle childhood, we've had some experience with death. In adolescence, however, our perception of death is slightly skewed in the sense that we feel death is primarily reserved for the elderly, and so therefore that leads to a lot of impulsive and high-risk behaviors from adolescents, which can lead to accidents. So texting and driving, drinking and driving, those kinds of risks can often lead to death in adolescence. But of course, as we have more experience with death throughout adolescence, we begin to understand that essentially no one is safe from death. And so what you're starting to see is that as we get older, starting in early childhood, especially once we get a sense of self and a sense of awareness, we just continuously have more and more and more experience with death. No one from these life stages has any more experience in death than adults. By the time you've reached the age of 40 or 50, you're likely to have experienced many deaths, deaths of grandparents, maybe even death of parents, maybe even a death of a sibling, death of friends, because the longer you live, the more relationships you form and the more opportunities you have to encounter death. When we die, we go through a grieving process. Specifically, when we are informed that we are going to die, we go through a grieving process, according to Elizabeth Kubler-Ross and her theory of dying. So her theory applies to individuals who are informed that they're dying, because obviously if we die unexpectedly, it's very difficult to go through all of these different stages. But for individuals who are diagnosed with, a short amount of time to live, and as well as individuals who have to deal with the death of a loved one, someone that they have an attachment with, grief can be a process that includes 5 different experiences or stages. Elizabeth Kubler-Ross, mentioned in her theory that not everyone necessarily goes through all of these stages or in this order, but these are the most common experiences, and in this order is the most commonly experienced way. So many people experience denial when they're informed that they are going to die, or that they hear of a loved one who's going to die or has died. They basically many times can believe that a mistake was made, or that it's not true, or that it's a bad joke. And so denial is a very common defense mechanism that humans use to alleviate anxiety, basically distorting reality and refusing to believe that death has occurred. Many individuals will often experience anger as well. Anger towards themselves for the decisions that they've made, anger towards doctors for not doing more, anger towards family members or friends for not doing more, and maybe even anger towards God for making the decision to take someone away. Bargaining is another common process that individuals may experience when they're experiencing grief. They may try to negotiate a deal, essentially, with a doctor, basically saying, asking, what if we do this, and what if we do that, and can we try this, and can we try that? Maybe even trying to broker a compromise with God, making promises to God if they are able to survive, they'll lead a good life, and those kinds of things. Unfortunately, for many people, their prayers are unanswered. And so when an individual realizes that there is no escape from death, or they realize that there's nothing that they can do to bring the person back, and essentially their anger is not really effective at changing anything, and their bargaining is of no use. This can be a very depressing experience when individuals become very sad because they're having to confront death. Ultimately, though, the main goal is that we accept the fact that, you know, death is a natural process. It's unfortunate at times, but it is inevitable, and it is reality, and something that we have to deal with and move on. Many people struggle with reaching acceptance of their own death or the death of a loved one. So as we grieve, we experience these feelings of anxiety and depression, and we deal with these different feelings of anxiety and depression through denial, through anger, bargaining, and our feelings or symptoms of grief are going to be influenced greatly by the strength and of the attachment with the individual. And there can also be some cultural differences as well. We see cultural differences in the way humans grieve. For example, in Mexican American culture, they have Day of the Dead, and that's a time where, you know, they can, you know, grieve in a way where they can remember the individual for their interests, and maybe provide some sort of offering to the individual, basically a way to remember the individual. This was made popular in the Disney movie Coco. Sudden deaths seem to have a much stronger impact and result in a much more complicated grief process. There are some individuals that grieve for an extended period of time, to the extent that it begins to interfere with, you know, their security and their own physical health. This can be diagnosed as prolonged grief disorder. The question presented here: what is a reasonable amount of time to grieve? And there is a joke here that says, we offer 3 days of bereavement leave. I'll take it that will be plenty of time to resolve your grief. Maybe 3 days of bereavement leave from your employer is enough time to resolve the grief of your pet or your great-grandmother who lived a long, full life. But is 3 days of bereavement going to be enough to resolve the grief with losing your child or losing your spouse? Maybe not. We see that, you know, some employers offer bereavement leave, maybe a week or 5 days, you know, paid time off. Obviously, every employer is different, and of course, there are some employers that don't offer this at all. So when we look at human development and we look at the grief process, which is, you know, a completely natural experience that, you know, the vast majority of humans experience at one point in their life or another, is it fair? Maybe that's not the best question to ask, but, you know, I think it's just important to consider that some people may have more resources to deal with bereavement than others. Some people may not have the time or funds to grieve, and that can interfere, obviously, with their mental health, because it's important to understand that bereavement is ultimately a mental health issue. You know, we're experiencing sadness and anxiety and despair. Now, of course, it's normal to experience these things, but at some point it can become abnormal or unresolved. And this is just basically an example of how some employers will allow you know, individuals to apply for additional time off, or you know, provide a highly reasonable amount of time comparative to other employers. Maybe even individuals can take unpaid leave. And then, of course, we have social policy here. We have, you know, people who can take up to 12 weeks of unpaid job protective leave. And what that means is that, you know, they are guaranteed to have a job when they return. So that is the conclusion of this chapter and this course. When discussing human growth and development, you know, we've talked about human development across the entire lifespan, from infancy or conception all the way to death. It's important to understand that development is lifelong. We are constantly changing. We change at a much more rapid rate in the first 20 to 25 years of life than we do on the back end of those years. It's important to understand that development is multidimensional, and so we have our physical development, our cognitive development, and our socio-emotional development. Development is multi-directional. That means we can progress and we can regress. We can make friends and lose friends. We can acquire information and forget information. We can gain weight and lose weight, gain agility, lose agility, all of that. Development is plastic. We're going to have experiences in our life, and grief might be one of them that changes the individual forever. They basically have a new perspective on life that is unchangeable essentially, once they've had an experience like the death of a loved one. Development is multidisciplinary. It's important to remember that fields like the legal system, criminal justice, healthcare, psychology, sociology, education, all of these different disciplines relate to one another. And in order to understand those other disciplines, and we need to consider what we know with regard to human development across the lifespan. And last but not least, it's important to remember that development is contextual. What is considered normal or average or typical development in 2020 may not be considered normal, typical, or average in 2050. There are certain things, certain behaviors that exist that are considered normal in the year 2020 that were not considered normal in 1950. You look at interracial marriage, you look at women in the workplace, you look at the increased amount of diversity that we have, you look at vaccinations, school shootings, the internet. What is considered normal now, what may not have been normal 30 years ago, and it may not be normal in 30 years in the future. So that's just something to keep in mind. And that concludes this lecture. Thank you very much.